Yes, yeah. So I think it's the cervical cancer in pregnancy is quite tough topic because it's rare. I have to admit that personally I don't have many patients, and perhaps maybe 1 or 2 patients a year, and we don't have evidence-based guideline management of cervical cancer in pregnancy because of the rarity of this condition. But of course, the treatment of cervical cancer in pregnancy or overall cancer in pregnancy is very complex. Alright, so the prevalence is about 1 in 1,000 to 6,000 live birth, which is maybe we can see 1 to 2 or 3 cases a year. And cervical cancer is third most common cancer diagnosed during pregnancy, and second women cancer diagnosed in pregnancy. First, of course, breast cancer, followed by leukemia, and then cervical cancer. Okay, basically pregnancy do not accelerate the disease, okay? And the pregnancy will affect, of course, pregnancy will affect the management of cancer. So when patient is pregnant and at the same time diagnosed with cancer, then the management will be affected because we are now in dilemma either to treat the patient or to salvage the fetus. So some degree will affect the management of cancer in terms of timing, in terms of type of surgery, type of treatment given. And then cancer will affect the management of pregnancy. This is common sense. Okay, cancer will affect the pregnancy outcome. Why? Because sometimes we have to terminate the pregnancy because we always give the priority to the mother. And then the treatment itself or the timing to deliver the patient also can actually cause a premature delivery. Then we talk about treatment-related complication, and in some case report there are also cases of placental and fetal metastasis in very few reports on malignant melanoma. When the mother suffer from malignant melanoma, they found that the fetus also get the cancer. Okay, general knowledge. I think very important for us to know something about general knowledge regarding the treatment of cancer due to pregnancy. So this is very extremely important when we counsel the patients. First 8 weeks of organogenesis are the most susceptible to teratogenic effect of radiation. Gonad is the most radiosensitive organ in human body. Permanent sterility dose for ovaries is 250 to 600 centigrade or red. 250 to 600 centigrade or red. And this is equivalent if you give a direct external beam radiation direct to the pelvis. Okay, radiation therapy given below the diaphragm depressed fertility in both sexes in 25%. Potential risk to genetic mutation in offspring is very minimal. And in this based on animal studies, only 1% if you give exposure of 100 centigrade or 100 rad. Okay, as far as pelvic radiotherapy in pregnancy, pelvic RT is absolutely contraindicated in pregnancy if the fetus to be salvaged. And if you give a pelvic RT, normally there will be a patient will undergo spontaneous miscarriage, usually within 4 to 4 days. Okay, what are the risks of radiation exposure to fetus? Just remember that the threshold for safety is 5 rad. Okay, this is the threshold of safety. Number 1 is, of course, miscarriage and fetal death, congenital anomalies, microcephaly and severe mental retardation, growth restriction, increased risk of malignancy in later life, germ cell abnormality to the fetus, leading to an infertility or genetic abnormality in next generations. Okay. If you look at the imaging diagnostic technique that commonly used in cancer, you can see that among all those imaging techniques, perhaps the abdominal CT scan has actually exceeded the threshold of safety. And then you can see the pelvic CT, abdominal CT up to 5 rad, and then pelvic CT scan. Okay, and the third one is bearing minimum. You see, other than that, quite okay. Abdominal X-ray, then the chest X-ray, chest CT, then you see the skull X-ray, IVP. Okay, right. But remember that the threshold for safety is 5 rad. How about chemotherapy during pregnancy? We don't have much data on this, but there is definitely a potential fetal complication such as a miscarriage, congenital anomalies, growth restrictions, myelosuppression, damage to fetal germ cell, damage to fetal visceral organ. And roughly the background risk of fetal anomalies after first trimester is about 10 to 20%. Okay. So these figures is important for us for counseling purpose. I'm sure that normally parents will ask us regarding what will be the chances of problems to their fetus. If you look at the FDA classification of drugs used in pregnancy, actually generally all the new antineoplastic drugs are categorized under category D, which is there is a positive evidence of human fetal risk. But the benefit from use in pregnancy, pregnant women may be acceptable despite the risk, except for the aminopterin. Aminopterin is the folic acid antagonist. This is totally contraindicated with pregnancy because of the toxic to the fetus, and also the methotrexate. Aminopterin, bisulfan, and MGX carries the highest risk. And methotrexate associated with MTD and clotting abnormalities, similar to aminopterin. Vinca alkaloid and bleomycin are safest drugs, and cisplatin are more preferred than carboplatin because less myelosuppressive and less protein bound, and therefore less transplacental transfer. Fetal bone marrow suppression can occur. Therefore best to avoid chemotherapy within 3 weeks of delivery. Many anti-neoplastic agents reach specifically level in the breast. Therefore, breastfeeding is not advocated in patients who respond to chemotherapy. Okay, when we talk about the cervical cancer in pregnancy, very important to make sure that you diagnose the disease. Cervical biopsy is mandatory to confirm the diagnosis. And generally, the pregnancy is not contraindicated to do a directed punch biopsy. The indication of cervical punch biopsy is similar to non-pregnant, and preferably we use a small and sharp biopsy forceps to avoid bleeding a lot, and try to avoid doing too many biopsies. If you remember, when you do a colposcopy in non-pregnant patients, sometimes we tend to do too many punch biopsy, nampak sikit small lesions, so punch until to the extent sometimes so many multiple punches until sama macam equivalent to a small lead, small cone biopsy. So try to, in pregnancy, please don't do that. Just get the most severe lesion, most suspicious lesion, and get good biopsy to that area. As far as the cone biopsy, as we have to try to avoid doing cone biopsy during pregnancy. I think because of the complication rate is very high. Number one, risk of preterm labor delivery is about 25%, and then of course in 50% of cases they found that there is residual disease after cone biopsy during pregnancy. Cone biopsy during pregnancy is only indicated for diagnostic purpose. It's not for therapeutic if possible. So there are at least three indications for the cone biopsy during pregnancy. Number one is to confirm the suspected cancer. We cannot confirm by punch, but it still looks very suspicious. Punch biopsy also do not actually settle the suspicious. So you have to do a cone biopsy when the invasive cancer is highly suspicious. And then cytologic suspicious and inconclusive colposcopy. And number three is when there's persistent major discrepancy between cytological, histological, and colposcopic findings. Okay, cone biopsy for therapeutic purpose, including the high-grade lesion during pregnancy, will cause incomplete treatment in 50% of cases. So we don't do cone biopsy in patients with CIN 2 or 3 basically. Perhaps there is very small role as far as cervical cancer is concerned. Maybe in patients who are early pregnancies and then they was found to have a stage 1, A1 for instance, and they refuse the treatment, and maybe they gravida 1, we want to preserve the fertility. Maybe the small, this probably a very highly selected patient where perhaps cone biopsy can actually be done for therapeutic purpose. Generally, this general management of cervical cancer and pregnancy. Number one, management depends upon the nature, the stage of disease, gestational age, and the wishes of patient and the family. Two, this is mandatory. Management must be by multidisciplinary teams, comprises of gynecologists, maternal fetal specialists, anesthetists, perinatologists, and also social workers. Given the moral, ethical, and emotional issues that surround this situation, the treating physician, which is gynecologist, social workers, perinatologists, and maternal fetal specialists should support the patient and help guide the decision-making process. Okay, these are basic guidelines for management of cancer during pregnancy in all cancers. Basically, if the patient presented at up to 20 weeks gestation, we normally give priority to the mother, therefore we treat and ignore the pregnancy. This is general rules. If they presented at 20 to 32 weeks, this is the most problematic dilemma on behalf of not only to a physician, but also to patient to decide between the maternal health and also the neonatal and fetal outcome. And generally, what we do is delay treatment and delivery. Both we delay treatment, we delay the delivery, okay, or treat and delay the delivery, okay. And third, if they are presented more than 32 weeks, quite easy to manage. So delivery and treat, or delivery followed by treatment, okay. Cervical cancer in pregnancy, most common gynae cancer in pregnancy. Most common female cancer in pregnancy is breast cancer, but most common gynae cancer in pregnancy is cervical cancer. The incidence is 2.4 to 4.5 per 10,000 pregnancies. But remember that patients with cervical cancer should not be allowed for normal vaginal delivery, regardless of the fetal conditions, because of these four reasons. Number one, because we're afraid of dissemination of cancer cell into lymphatic or vascular channel. We have fear of hemorrhage, bleeding, cervical lacerations, and also tumor implantation at the episiotomy sites. There's four reasons, regardless of the condition of the fetus. Principle of management of cancer of cervix in pregnant similar to non-pregnant patients. Inoperable disease, radical hysterectomy and pelvic nephrectomy, and can you perform fertility sparing surgery in certain selected cases. And in inoperable disease, radiotherapy plus minus chemotherapy. In metastatic disease, chemotherapy. I think all this has been highlighted clearly by Prof. HT earlier. Inoperable cervical cancer. Majority of patients in pregnant patients presented with cervical cancer, they are presented at the operable stage. 82% of invasive cancer in pregnancy is operable. So at a gestational age of less than 20 weeks, normally the option of treatment will be, the best will be perform the radical hysterectomy and pelvic nephrectomy with fetus in situ, as I mentioned earlier. But there is of course an option. Again, as I mentioned earlier, the decision will be based on discussion, thorough counseling between all clinicians and also patients, and decide. And of course, the decision will be a collective decision, and we have to actually respect the patient's wishes. Okay, and some patients they refuse treatment because they want to conserve their pregnancy. Okay, despite of counseling. Okay. In that situation, perhaps we can delay the treatment. Okay, and then treat later. At gestational of 20 to 28 weeks, this is a major dilemma. There are few options, at least 3 options here. Okay, delay the treatment 6 to 12 weeks. Of course, we have to be very selective. Not all cancer can be delayed the treatments. Some aggressive cancer, advanced stage cancer, you cannot delay the treatment. But in slow-growing tumor or in acceptably non-aggressive histology type, perhaps I'm talking about cervical cancer, you can actually bring the pregnancy up to 6 to 12 weeks. but provided this patient is seen by a gynecologist, regular follow-up, regular monitoring by imaging by MRI, okay, and we can wait up to 12 weeks. The second option will be quite controversial. You can offer neoadjuvant chemotherapy, okay, and then bring the pregnancy up to the viability, fetal viability, followed by classical cesarean section and radical hysterectomy subsequently. And of course, the third option will be immediate treatment if the cancer is very aggressive, something like squamous CA, or maybe you're dealing with small cell neuroendocrine disease or the cervix. Patient with gestational age of more than 28 weeks, you can delay up to 24 weeks and deliver the baby by classical cesarean section followed by treatment. This is we encountered a few cases. This is one of the patients who actually presented 31-year-old, gravid at around 1 at 22 weeks and presented with persistent genital bleeding, and she has a stage 1B1 cervical cancer, well differentiated glandular papillary adenocarcinoma of cervix, and MRI showed localized disease. Basically, we treat conservatively. We wait until the fetal viability, and just to highlight that performing the radical hysterectomy during the peripartum period is not more difficult than the non-pregnant patients. In fact, the tissue plane is quite easy. The tissue sedimentous is quite easy to open the space and so on. So it's okay. But of course, it should be performed by trained personnel. This is a specimen. We did a cesarean section, classical cesarean section, followed by a radical hysterectomy and pelvic adnectomy. Baby is okay. In certain situations, you cannot delay the treatment, please. Because delaying treatment actually compromises the maternal outcomes, the maternal disease, such as if patient has a poor histology type, poorly differentiated tumor, squamous, small cell neuroendocrine, patient in advanced stage disease, and of course non-viable pregnancy. This is specimen actually taken from the papers published by Dato' Prof. Siwana Saranam, who did radical hysterectomy with the uterus in situ, and she presented with cervical cancer in early pregnancy. In case reports, there are of course fertility preserve surgery done in patients who presented with cervical cancer in early pregnancy. This is selected, isolated case report who actually published by Laszlo Ungar from Hungary at 5 case report. She presented with cervical cancer in early pregnancy, and then they refused treatment. They refused, definitive treatment, and but she wanted to preserve her fertility, her pregnancy. Then the trachelectomy was done, exactly what had Dr. H.K. described. So the abdominal trachelectomy was performed, and pelvic lymphadenectomy to preserve the pregnancy, to preserve future fertility as well. So this is few isolated case report where the trachelectomy was performed during pregnancy. Inoperable cervical cancer is relatively less common than operable disease. In 80% of patients presented with cervical cancer in pregnancy are actually inoperable stage, 2B and above, with the prevalence of 4 to 8 cases per 100,000 pregnancies. So in early gestation, patient has to be treated with EBRT with the fetus in situ. The majority will be spontaneously aborted, followed then after abortion, after miscarriage, then only followed by brachytherapy. And normally these patients, the fetus will be spontaneously aborted after perhaps 2 to 3 weeks. In later pregnancy and viable fetus, deliver the baby by classical cesarean section followed by radiotherapy or chemoradiation. There are also case report of giving a new adjuvant chemotherapy. In this case, 26-year-old women, gravid 4 para 3, at 14 weeks gestation. she was diagnosed with Alphago stage 2B squamous cell carcinoma of cervix at 14 weeks gestation. And she refused definitive treatment, and therefore she was offered a neoadjuvant chemotherapy with cisplatin bleomycin for 4 cycles, and then she was delivered by cesarean section at 34 weeks of period gestation. And the baby was normal and had no problem with neuropsychomotor development despite of in vitro exposure to chemotherapy. Okay, these are the take-home message. Management of cancer in pregnancy requires a multidisciplinary approach with due respect for the wishes of the woman and her family. Cervical cancer is the third most common cancer diagnosed during pregnancy. Principle of management similar with non-pregnant women. Certain radiological investigation pose potential threat to the fetus. Pelvic radiotherapy is absolutely contraindicated in pregnancy if fetus is to be salvaged. Chemotherapy during first trimester associated with significant risk to the fetus. In selected cases, cancer treatment can be delayed to achieve fetal viability without compromising the maternal outcome. And finally, in selected cases, cancer treatment can be offered to pregnant patients even with the intention to salvage the fetus. With that, thank you very much for your attention.
Thank you very much.